Um, okay, good afternoon and welcome to everyone at all of our remote sites. My name is Colleen Crowley and we are broadcasting today. I'm Colleen Crowley, I'm the Executive Director of the Northwest Parkinson's Foundation. We sponsor the program with the Parkinson's Resource Group out of Spokane. And again, we're broadcasting today from Virginia Mason. And we do have some folks in our room with us here, so I just wanted to let them know that we're going to actually not be talking to you, but rather to the screen because that is being broadcast to the 22 different remote sites. So let me get started. For those of you who did not receive the information, our speaker who was scheduled for today had a death in her family and was unable to be here, and we are enormously fortunate to have two outstanding professionals step in to do the presentation for us today. And the topic is going to be voice and swallowing therapies for Parkinson's patients. So the two professionals we have today are Yumi Sumida and Taunya Myer, Dr. Taunya Myer. So let me tell you a little bit about Yumi. She's going to start. I'm going to put my glasses on so I can read it. Yumi received her MS in Speech Language Pathology from the University of Washington. She completed a competitive fellowship in voice and swallowing disorders at Emory Voice Center in Atlanta, Georgia. She's currently a clinical specialist at Harborview Medical Center, where she focuses on voice and swallowing disorders. She works primarily in the otolaryngology department. I was trying to practice that word. But works closely with acute care and rehabilitation teams. And she is certified in Lee Silverman voice therapy for individuals with Parkinson's disease. In addition, she's also actually has an MFA from the American Conservatory Theater, which is a pretty cool combination. So this is Yumi, and next to Yumi we have Dr. Myer. Dr. Myer completed a Laryngology Fellowship with Andrew Blitzer at the New York Center for Voice and Swallowing Disorders. Since that time, she has practiced in Maryland at the University of Maryland Medical Center and University of Maryland Shock Trauma Center. More recently in Seattle, she was at the University of Washington and Harborview Medical Center, where she, in fact, helms the new Specialty Voice and Swallowing Clinic. She has a special interest in laryngological, you guys will have to say it for me, I'm sorry, complaints of neurologic origin, such as Parkinson's disease. She completed her residency in otolaryngology at the Medical College of Wisconsin. She did a residency in general surgery at the University of Rochester and was a research fellow at Lindbergh Comprehensive Care Center at the University of North Carolina. So they are very, very accomplished. I didn't even bring their whole VTAs because they were so long that we would have taken the whole time talking about all of the work that they've done. But they have a great topic for us here today, so they're both going to present separately. And then, again, to remind everybody who's checking in today, the way we do this is we'll have the presentation, and at the completion of the presentation, we will go down a list of all of the remote sites and call out the individual sites. And if you have questions, you can ask the questions, and then they will be here to respond. So we'll do them one at a time, and when you do that, you need to unmute your button to ask the question. After you've asked the question, you need to remute your button so that you can hear the answer. So without further time, we'll start with Yumi.
Great, thank you, Colleen. So my PowerPoint slides will be coming up in a minute, but I just want to say I'm really happy, excited to be here with everybody in the room and at our remote sites this afternoon. As Colleen said, I'm a speech-language pathologist at Harborview Medical Center, and I don't see my slides up just yet, so let me tell you what I am going to be doing. First of all, I want to state that I have no relationships with any of the companies represented in this talk. So this is purely speech pathologist to patients. This is a rough outline of what I'll be covering today. So first of all, I'm going to talk a little bit about the voice problems related to Parkinson's disease, the voice therapies that are known to work, swallowing problems, and then the swallowing therapies. And my talk will focus very much on the therapeutic management of voice and swallowing problems. Dr. Myer will address some of the surgical medical management issues. Okay, so just here's a little basic review. This is something we all know, but just so we're on the same page, I want to simply review that Parkinson's is a neurologic disorder, a brain disorder, where the motor pathways that are involved in planning and initiating movement are altered, degraded. Parkinson's comes with a variety of symptoms, motor and non-motor, and it's very important to remember, even though we talk in very broad generalizations about these symptoms, that every patient, every individual who has Parkinson's is different and may present with slightly differing symptoms. And that's something that we all need to keep in mind. Okay, so what are the voice and speech deficits associated with Parkinson's? Well, there is a term we use. We call it hypokinetic dysarthria. And it's a term used to describe a type of speech pattern that's often noted with Parkinson's. It affects both the voice, so the basic instrument of projection and phonation, and it also affects our speech patterns. So when we think about speech patterns, we talk about intonation and speed and rate and things like that. Hypokinetic dysarthria is specifically characterized by soft, quiet speech, which is decreased loudness, a fast speaking rate, and some variation in that speaking rate. So sometimes some phrases just come out very fast, and some just are at a slightly different rate. So there's a variability there. A monotone voice quality. And when we say monotone, we're thinking mono both in pitch, so it all stays on the same pitch level, but also monotone in loudness, so it all stays at this very kind of a set level. Lack of clarity and imprecise articulation is another marker of hypokinetic dysarthria. Some studies estimate that up to 89% of patients with Parkinson's experience some form of voice or speech disorder, but only 3 to 4% seek help. And maybe that's because it's not bothersome enough for people to seek help, but I think that's an interesting fact. Makes you wonder how much people know about the therapies out there. So what are the therapies and how good are they? Well, the most well-known therapy for voice and speech disorders associated with Parkinson's is called Lee-Silverman voice treatment. Now, Lee Silverman was a patient, so it's not named for the founder or anything like that. In fact, it's always a little bit odd when people say, well, who was Lee Silverman? He was a patient. But some researchers, investigators in Colorado developed this particular therapy specifically to address the deficits or the hypokinetic or the features seen with hypokinetic dysarthria. There is some very strong evidence to support Lee Silverman voice therapy, and that is one of the reasons it's become so popular or so well known, is because the evidence to support it is so strong. Now, let's look a little bit more at Lee Silverman and some of the important concepts associated with Lee Silverman voice therapy. So, number one, increased loudness. This is at the core of the therapeutic regimen. And the thinking is that with that increased loudness, you also get increased clarity and increased or improved articulation. Two, there's a large emphasis on effort, on really working hard to get the sounds out, and really encouraging people to work hard and produce. Three, this is very important, it is intensive. It requires a pretty substantial commitment from both the patient and the clinician. So it requires attendance 4 days a week for 4 weeks, so for a total of 16 sessions. And then there is homework on top of that. So the home practice component is also an integral part of the therapeutic plan. The goal of the therapy is what they call recalibration. And this is one of the really important point with Lee Silverman voice therapy. It's not just to produce loud voice, it's to help the patient understand why their voice has gotten soft and to help them adjust that. So the thinking is that individuals with Parkinson's don't realize how soft they are talking, or how that their voice is not audible to other people around them. And so by encouraging people to be loud and giving them continuous feedback, we are resetting or recalibrating that particular patient's inner sense of what loud and appropriate is. Okay. And finally, it's very important with the therapy that the therapist provides consistent feedback, and is, we are instructed to really be very specific in our feedback and to be very motivating and positive in our feedback approach, and with constant feedback for a certain period of time. The therapy is unusual in that it requires a certain certification by the speech pathologist to actually perform it and call it Lee Silverman voice treatment. So that's just something to know. When we talk about evidence in the medical field, we think that the highest level of evidence is the randomized controlled trial, where you have two groups that are blinded, that receive different therapies, and where the people who are judging the outcomes are also blinded. And so we know from some well-conducted studies, actually two randomized controlled trials, that look at Lee Silverman voice treatment and show how well it works. Over the years, the investigators have looked at how well those therapeutic gains are maintained. And we know that, for instance, some of these gains can be maintained for up to 2 years for some individuals. So it has some lasting, it can last a while too. Lee Silverman voice therapy treatment is best suited for those individuals with mild to moderate Parkinson's who are kind of stable with their medications in a situation where they really want to work hard to improve their voice and communication. It requires, as I said, a substantial commitment. Now, one of the drawbacks of the Lee Silverman voice therapy is that it requires attendance 4 days a week for 4 weeks. So the developers came up with what they call Lee Silverman Extended. And this simply is just an alternate schedule. So people can attend therapy twice a week for 8 weeks. It's still the 16 sessions, the same principles apply. And they are looking at how well these altered schedules work now. And they're seeing that they actually work quite well, although I don't know of any studies that compare the first schedule with the second schedule and so on. Okay. Now, LSVT is not the only therapy out there. There are other therapies, although the other therapies do not have that same level of evidence. That doesn't mean they don't work as well. It just means those studies haven't been conducted or designed yet. Okay. So let me talk a little bit about one therapy that is sort of interesting. It's called choral therapy. And so this requires patients to attend therapy with a speech pathologist twice a week for 10 weeks, so that's 20 sessions. But it also requires a weekly choral practice or singing practice, essentially choir practice. So once a week, people go for a 2-hour choir practice session. And this is an interesting approach, because when we do voice therapy, we often borrow exercises from the singing world for the same reasons that singers use them, to increase our pitch flexibility and so forth. And the outcomes from this choral therapy study show that people develop increased lung volumes. Their maximum phonation time, or the amount of time they're able to hold an actually increases. And that's a marker that we use to look at vocal endurance. And that their prosody, or their inflection, and their intonation actually improves a little bit too. So they lose some of that monotone voice quality and develop a little bit of pitch and loudness flexibility. So I think that's kind of interesting. Okay, so what are some of the take-home messages from this voice piece? Well, one, hypokinetic dysarthria is frequently seen with Parkinson's. We know that LSVT, or Lee Silverman voice treatment, works. It also requires substantial commitment. We know that other therapies work. And what do all these therapies share? Well, they seem to share one thing, which is an emphasis, or two things maybe, an emphasis on doing. So there's a lot of practicing that goes on. There's a lot of vocalizing that goes on in these therapies. You don't sit around and listen a lot. You kind of sit up and do. And the other thing that these therapies seem to share is an intensive, the intensive approach. So 16 sessions, 20 sessions, lots of home practice. And that seems to be really quite important. So how do you go about, finding yourself a voice therapist and getting enrolled? Well, look to your local speech pathology community. And I would guess that most of the sites where you're located will have an excellent speech pathology team that can either guide you to somebody who is specialized in treating Parkinson's voice and speech disorders, or they may even specialize in that themselves. So that would be a good place to start. There is also a website for the Lee Silverman Voice Treatment. They list clinicians. However, I have to warn you, the listings are often out of date, and even though they're supposed to be kept up to date, so often they don't truly reflect who's available in your area. And I'm one of those. I'm on that list of. I'm certified, but somehow I can't get listed there, no matter how many emails I send. Okay, so I am going to switch gears and talk a little bit now about the swallowing issues, okay? So, dysphagia, or sometimes called dysphagia, is the term we use to describe swallowing disorders. And not all dysphasias are the same. And this is because swallowing is a really complex activity. So when you break it down, we think that maybe 50 pairs of muscles are actually involved in one swallow. So those 100 muscles have to be really well coordinated, very precisely timed in order to get the food from the mouth to the stomach, okay? And let me point out some landmarks on my picture here, because this is important. So if you can see my pointer here on the PowerPoint, this is the tongue, and the tongue is responsible in the oral phase of the swallow for preparing the food, for getting it ready, for getting it into a nice little parcel, or what we call a bolus, that will then be sent down the hatch, okay? So lingual function is really, really quite important to eating and swallowing. Here, this is the trachea, or the windpipe, which goes to the lungs. This is the esophagus, which goes to the stomach. Now, what you may notice, or what may be hard to notice in the diagram because of the coloration, is that these two tubes actually open into the same portal. And there you have one of the key problems with swallowing, is the body has to be well coordinated enough to protect the airway and get the food down into the esophagus. Okay. So in a normal swallow, the food is prepared in the mouth, the tongue propels it back into the throat. Now, as that happens, there are a number of other events that happen simultaneously, like that. So I'll go through them one by one. Here, this is what we call the velum, elevates and closes off the nasal cavity from the oral cavity, so food doesn't go up the nose. This whole laryngeal complex elevates as part of the protection mechanism. These pharyngeal constrictors push and help get that food into the esophagus. And there's a muscle here that stretches open that allows the food to pass easily into the esophagus. In a normal swallow, all of those events occur in 1 second or less. So you can see that if the movement or the timing is off in any way, it can have some dire consequences. So what are some of those consequences? Well, what if the tongue is inefficient and doesn't push well enough? What would happen? The food would sit in your throat. What if the larynx doesn't elevate and the throat doesn't squeeze and the airway isn't protected? What would happen? Food and liquid might actually go down the wrong way into the trachea. And that's what we call aspiration. And that's quite dangerous, life-threatening, because if you aspirate a large piece or chunk of food, you can cause airway obstruction. Also, if you aspirate chronically, some of that food bacteria will build up in your lungs and cause a pneumonia. So aspiration is one of the things we talk a lot about with swallowing disorders. Okay. We'll talk for for a moment about silent aspiration. So what is that? Silent aspiration occurs when we have decreased sensation in the throat. So for most of us, if I were to aspirate, I would start coughing up a storm. You would know something was wrong by the way I was coughing and reacting. If you have decreased sensation in your throat, you don't cough when something goes the wrong way. You may not even know, and that's particularly dangerous because if you have little amounts being silently aspirated over time, that can really set you up for a problem. Aspiration is not the only problem associated with dysphagia. Oftentimes, it's just the effortful nature of eating that is a problem. And this can lead to longer meal durations. People will stop eating some foods that cause them more problems. And over time, this can lead to unintentional weight loss, malnutrition, and dehydration. With the Parkinson's population, various studies have looked at prevalence, and we think about approximately 1/3 or more individuals experience some level of dysphagia. We think that dysphagia in Parkinson's is highly correlated with decreased gross motor skills. There are studies that show the unintentional weight loss with Parkinson's is actually associated with dysphagia. And we know, and I'm sure I don't need to tell you all, that the dysphagia can really and significantly degrade your quality of life. We also know that aspiration is a common cause of death in Parkinson's. And studies have looked at the medications and how much they affect the swallow, and it's kind of mixed. So the medications do not always improve the swallow symptoms. Okay. So what are the specific deficits? Well, coordination. Coordination is everything. So if we think about Parkinson's as a movement disorder and swallowing as an activity that has to be highly coordinated, you can see where you get into trouble. All of those small events having to take place in a sequential manner, if that becomes discoordinated or poorly coordinated, you can really have some problems. So we see poor tongue function, right? And so therefore we don't prepare the food as efficiently. We see decreased laryngeal elevation, decreased pharyngeal constriction. So all those things I talked about back there, all of those things can be affected. Also see some decreased sensation and silent aspiration. The last item on the list is kind of interesting, drooling. We also have a fancy name for it. It's called sialuria, okay? And it's frequently seen with Parkinson's. In fact, we estimate that almost a half of the individuals who have some form of dysphagia with Parkinson's experience this sialuria, okay? And let me talk a little bit about the sialuria because the mechanism for it's kind of interesting, and Dr. Myer will talk a little bit about this too. So most of us notice the buildup of saliva in our mouth and throat, and we're swallowing constantly, all day long. We're kind of not thinking about it. We're swallowing. If your sensation is decreased, you don't realize that stuff is there, and you're not swallowing it. So what happens, it has to go somewhere, right? So it can either come out this way through the mouth, or it can trickle down the back and into the airway. So you can aspirate some of your saliva, and you can drool. And so we think that when we see that drooling or sialuria, that's actually a marker for dysphagia in this population. So what are the swallow therapies available? Well, unlike the voice, there's no one fixed therapy that has a tremendous preponderance of evidence to support it. What we're looking at is really pretty much traditional swallow therapies. And traditional swallow therapy has several components to it. So one are the exercises to improve the strength of the musculature, right? Sometimes the modalities involve some form of biofeedback, so you learn how well you're doing, and you can, it's very effective. Some methods of the therapy involve some form of stimulation, because we know the swallow works really well when it's strongly stimulated with cold things, etc. So we have those things that are designed to improve swallow function. Other therapeutic approaches include teaching people protective maneuvers. So teaching them how to prevent aspiration by doing clever things like turning their heads, etc. And then the final method of management is dietary modifications. And that's usually the one I like to go to the last, because it's the one that really, I think, impacts quality of life as a management strategy. There are other types of swallowing therapy out there that are non-traditional, and I'll talk a little bit about some of those too. Okay. So the exercises, as I said, they're designed to increase the strength of certain parameters. So some are actually designed to increase laryngeal elevation. Some are designed to increase pharyngeal constriction. Biofeedback, as I said, is often used, and I think home practice is a really important part of this type of therapeutic approach. Stimulation. So as I said, we know that when you stimulate certain parts of the mouth and tongue, so we call them the anterior faucial pillars, and as you can see, I'm moving my mouse right here. It's really on the side of the cheeks, right there. If you go and stimulate that with something that is very cold or very sour or very spicy, it can stimulate a very strong swallow response, meaning the muscles will contract a little bit more forcefully than they normally do. And we think this is a nice therapeutic strategy to get those muscles working a little bit. Protective maneuvers. I'm sure some of you have heard of the famous chin tuck. There are others too, and they all serve a purpose. Dietary modifications. I think this is really important. If you are modifying someone's diet, I think it's really important to get a dietitian involved, because it's very easy to sort of miss out on the important nutrients if you do that. Other swallowing therapies. You know, interestingly enough, LSVT has been shown to improve swallow function as well. There is also, they call them expiratory muscle strength trainers, and there are these little things that you blow into, and they work the muscles of expiration, and they have actually been shown to improve cough strength and efficiency. There also are some, there have been some therapies to use biofeedback for drooling, and those have sort of mixed results, but positive, generally positive. Now, this is a really important part with the swallowing therapy. There is no one-size-fits-all swallowing therapy. A good therapeutic program is designed by a speech pathologist who really takes the time to assess exactly what your specific needs are. Because not everybody is the same, and you certainly want to be doing the exercises that are going to benefit you the most. So it's very important to remember that, because, so for example, a chin tuck is protective for most people. It can protect the airway, but for some people it can actually not be a good thing. So it's very important to really work with a speech pathologist on these swallowing strategies. And at this point, I'm going to hand the podium over to my colleague, Dr. Taunya Myer, who works with me at the Voice and Swallowing Clinic at Harborview. Do that, I'm going to get her slides set up. And there we go. Whoops, that's neutral.
Okay. All right. Thank you, Yumi. That was great. And we'll move on to Dr. Myer. Thank you.
Thank you again for inviting us and letting us speak to this lovely group. And again, I'm Taunya Myer. I'm a laryngologist. So it means that I'm an ENT doctor that specializes in diseases of throat and swallowing and of the voice. And so for this reason, we take special interest in different disease processes that have any trouble with swallowing or voice dysfunction, and we do see that somewhat in Parkinson's disease. And there we go. And so as an otolaryngologist or as a physician, my main two goals in the treatment of individuals with Parkinson's disease is to do anything that I can possibly do to improve their quality of life, but also to prevent any potential complications from any issues that they may have. And so in terms of the voice, that is, for the most part, a quality of life issue. So as we know, individuals with Parkinson's can have a soft, monotone voice. Their voice can be unclear. They can develop a stuttering quality and almost a breathy quality to their voice. That can make it difficult for them to communicate with their caregivers and communicate to their friends. In terms of swallowing, we ask whether or not there's any coughing with meals, if there's aspiration, and Yumi's gone over some of this stuff. We worry about patients that are drooling, and in general, we think that's not because they're making too much saliva, but often because they're not swallowing as frequently as they had in the past, the saliva builds up in the mouth and then runs out, especially as many of these patients tend to have somewhat of a stooped posture, so the saliva can run out the front of the mouth, or when they're reading the newspaper or reading a book. And then we always worry about risk of pneumonia. I want to bring up one small issue in that if this group of patients has any sleep disorders, if they're snoring or any witnessed apneas by their spouse or by their caregiver, this is something that should be brought to the attention of their neurologist or of their physician, as sleep disorders can herald a different type of Parkinsonism, multi-system atrophy or shy dragger, and that definitively we'd want to know about. And these individuals may benefit from further evaluation or even getting a sleep study or the use of a sleep apnea machine. And so in our evaluation of these patients, we always want to look at how our therapy and how our intervention will fit in context of the severity of the individual's disease, what their associated symptoms are, and also whether or not their medication is maximized. So we always work in conjunction with the neurologist and with the patient's internist, and we always want to make sure that their medication strategy is maximized, because all of our therapies are just adjunctive and only support the main baseline therapy of the medication management. And so an individual may come to me saying, my voice isn't as clear as it used to be. People don't hear me when I'm at a restaurant. Or the spouse may come to me and say, you know, I just can't hear him or her as well as I used to. And then there's usually this dialogue, I'm speaking just fine, you need hearing aids, so on and so forth. And a lot of this comes because of the disease process itself. With individuals with Parkinson's disease or Parkinsonism, they have a scaling down of their motor output. And so what they perceive as being full output actually may not be full output. And that's why therapy, both for motor output such as walking, and why therapy for voice and swallowing is so effective, because we have this target. We can scale up that motor output. So when you come to see an otolaryngologist for Parkinson's, one of the things we want to do is we want to look at the larynx. The larynx is the voice box.
Can you dial back to us? I'm not sure what
You can see that they're bowed. So instead of coming and closing completely, they close in this spindle shape or this bowed pattern, and there's these gaps here before and sometimes even after two gaps in the closure. This is one of the reasons why the voice is weaker and why the swallowing can be weaker. This isn't the only reason. This is in tune with many of the motor deficits that go along with Parkinson's disease, but this is very common to have vocal fold bowing, and that contributes to the voice and the swallowing difficulty that we see. But again, it's a target for us as a physician. We see, there's a difference here. We can address that difference to help the individual. And so again, when we do this examination and we see what the deficits are, we want to take all of these points in context of the individual's overall disorder. In general, for the therapy and for some of the interventions I'll talk about as an otolaryngologist, this works for patients that have an overall fairly good functional status in terms of a strong gait and in terms of a strong respiratory drive. But we do want to ask about many things. We want to ask about change in swallowing, change in gait? Are people tripping more? Are they still able to get through doors? Are they using a cane? Change in handwriting, change in fine motor tasks. Are they able to do their activities of daily living? Can they still button buttons or zip up zippers? And we always like to query the spouse or the caregiver for additional input. And most but not all voice changes are accompanied by some degree of dysphasia, but unfortunately, because this is a progressive disease of variable onset, patients may not fully recognize their degree of difficulty swallowing because they'll subtly start to change their diet, or they'll subtly start to have more problems, but no one will really notice it. So it's something that's important for us to query when you come to the office. And these are some of the questions, and you've gone over these already with Yumi. Coughing with eating, trouble with liquids. An important question or important thing to ask or thing to consider is it taking longer to eat your meals, or is your spouse taking a lot longer to eat their meals? And it's something that you can even time. And again, we also ask whether or not the individual may still enjoy eating at restaurants or eating with their friends, or if they're limiting their water intake, because water may be one of the most difficult things to swallow. And finally, we want to know if they were avoiding certain types of foods. And again, this just is another slide to remind us that we really want to look at the overall condition. We would like to make sure that you're actively optimizing your medication with a neurologist. And finally, just like every other person, you need to make sure you get enough sleep, that you're actively pursuing some sort of exercise program so you're keeping your entire body in good condition, and that you're pursuing an adequate diet. So the number one therapy for any type of Parkinson voice or swallowing problem would be voice or swallowing therapy. So there's a bunch of different types of therapy. The Lee-Silverman voice therapy is the one that's most commonly known and highlighted, but they all have the same vein of intensive exercise or intensive therapy that's trying to reset the baseline motor output. So we want to take that patient's baseline motor output and we want to reset it at a higher level. But as we talked about before, and as we showed you with the vocal fold bowing, we do have some anatomical targets that we can go for as a physician. And basically that anatomical target is that vocal fold bowing that can be very commonly seen in Parkinson's. And this is an image. Basically what we can do is if that vocal fold is bowed out, if we take either an injectable material or if we take a strip of silastic or a strip of Gore-Tex, we can tuck that underneath the vocal fold and straighten that vocal fold edge so it's easier to get the vocal folds together in a straight manner like I had shown you would be the normal larynx. So that's very useful and very helpful because it allows the individual to get their vocal folds closed so they don't leak air, and get their vocal folds closed so that they swallow better. But again, it's useful for the patients that have enough functional capacity that they're still able to mount a strong swallow, mount a good deep breath to drive the vocal folds, and that aren't having such dense swallowing deficits or dense cognitive deficits that it overcomes the minor alterations we can make here. The last therapy I want to talk about is for drooling. So again, we mentioned that some individuals with Parkinson's disease, they don't make more saliva, but because they're not swallowing as frequently as they would in other circumstances, or because they're hunched forward so that the saliva tends to fall to the anterior portion of their mouth, they can struggle with drooling. And this can be embarrassing socially, and it can also be problematic because as they're trying to enjoy a book at nighttime or enjoy the paper, they're drooling onto their book or onto the paper. And we can help that with botulinum toxin or other medications that can decrease the amount of saliva. It's a double-edged sword because if you decrease the amount of saliva, then your mouth is dry. And also some of those medications, especially the botulinum toxin that we can inject into the glands that create the saliva, can also create a some additional component of trouble swallowing. So if the individual is drooling but doesn't have an associated significant amount of trouble swallowing or dysphasia, then we would be fairly comfortable using the botulinum toxin with those individuals. But if there's a lot of swallowing disorder, then we may be more careful about that. And I think that's about it for the medical aspect.
We can both come up then. Okay. Okay. Well, thank you, Dr. Myer. That was great. And Ms. Sumida. So now we have the opportunity to go to our remote sites and ask questions. I'm going to step out of the frame a little and let the two of you then field the questions that we get from these folks as we go to each one. It takes a minute or so, or a few seconds to connect in with those guys. So we'll start with Anchorage, which I know has checked in. So Anchorage, do you have any questions today?
Yes, this is Anchorage, Alaska. We do have one question.
Okay.
This has been really good and very helpful, and my husband does have this problem and has been through the speech therapy, so I know how much help it can be. Are you hearing me? I don't think so. I don't hear anything now. And they've got a different picture.
Can you hear us? Because we now can't hear you.
They're showing a different picture.
Go ahead, Anchorage. I think they can hear you.
Okay.
Okay. So anyway, this was very good and helpful, and I appreciate it very much. But also, I was very interested in the program on apathy, because that's becoming a large problem for Roy. And I wondered if you're going to reschedule that one. They said something about have to push the button.
We have lost you, I think. Hello?
They've lost us. I think we're talking to the wall.
Hello?
This is Spokane. Bear with us for one moment. We're reconnecting to Virginia Mason.
Anyway, since you know my question and you have the thing, why don't you go ahead and ask it? Because
This is video support at St. Luke's in Spokane. Please bear with us. The Parkinson's support endpoints. We lost our video call to Seattle and we're reconnecting. Bear with us for one moment.
All sites in the Parkinson support group. The call from Virginia Mason got dropped from their end. They're working on reestablishing the connection. If you just stay with us, please.
Okay.
This is the room operator at St. Luke's in Spokane. Please bear with us. We're still trying to reconnect the Virginia Mason room from Seattle. We apologize for the delay. This is the video operator here in Spokane. While we're waiting for Seattle to get reconnected, we have a guest speaker who is going to say a couple words. It's Doreen Nicholas from Eastern Washington University, with Eastern Washington University. Please bear with us. Thank you, Doreen.
Oh, you bet.
Different microphone, just
Okay. Well, I thought I'd just take a few minutes to talk about what we're doing here in Spokane with our Treble Clefs group, which might be something some of you want to look into in the other sites. So once a week, we're meeting at a retirement facility. Actually, they're gracious enough to let us use their facilities. And we get together for some loud singing. And we start with vocal warm-ups, about 10 minutes of vocal warm-ups, and then we move into about 50 minutes of singing. And we've actually, the reason I got into this program was because I teach for Eastern Washington University and Washington State University, is to get our graduate students involved. And so that's a nice little network for our graduate students to be exposed to people who have Parkinson's, and also for our Parkinson's patients. I think they really enjoy meeting our graduate students. So once a week, we're getting together and doing some warm-up exercises, some calibration exercises, and some singing. And this, I don't know, how long has this been going on? I've been involved about 2 years.
This is the 6th year.
The 6 years. And so
and we've been working with you, and you tell folks who you are, what you do.
okay. Well, okay, I'll back up. Yeah, I'm a clinical instructor for Eastern Washington University and Washington State University, and I'm a speech pathologist, and I am certified in LSVT. And so the Treble Clefs have been going on for about 6 years, and we've got one of our founding members here, Ruth. Wave at the crowd, Ruth. And also our other founding member is a speech-language pathologist, Sarah Nielsen, who...
For conference chairperson services, press the pound key. All other participants, please wait.
Okay, everybody's seeing me. Okay.
Thank you for your patience, Alaska. Okay, is that Anchorage?
Okay.
This is Anchorage, Alaska. Hello?
Okay, thank you for your patience.
Hello.
You could ask your question.
Can you hear me? This is Anchorage, Alaska.
Yes, we can hear you.
Okay, we have someone here that had a question. She thought that this discussion today was excellent, but she felt that we would come to talk about apathy. And so she wondered if that's going to be done at another time.
Yes, we probably will try and get back to that again. Our original speaker had a death in her family, and so she was unable to be here today. So we were fortunate to get this really interesting talk in and present it today. So we will certainly try and get back to that.
That's just fine. It's just that that was kind of the help she needed. But this was very interesting because we all need the speech part. So thank you so much.
Good. You're welcome. Any other questions there?
Oh, we have no more questions.
Okay, thank you. And if you would mute your button, we'll go to Billings, Montana. Oh, we're in a dark room. Any questions from Billings? Okay. Let's go on to Clarkston, Tri-State Memorial Hospital.
Yes, hi, good afternoon. We have 3 questions. The first
great.
question was our first speaker.
Do you push the button? Can she hear you?
Yes, she can hear me. Our first speaker gave a list of dietary modifications, the first which was thick liquids, but the list went by so quickly we couldn't get the second 2. Could you repeat those for us?
You know, I actually didn't list them all, and I didn't specifically because they're going to be different for everybody. But I will elaborate a little bit on the thickened liquids. So water travels very fast, really fast. So if your swallow is poorly coordinated, it is sometimes necessary to thicken your liquids. Liquid thickeners can be purchased at most pharmacies. They will never be stocked at eye level. You will generally have to ask the pharmacist where they hide them. But most of these liquid thickeners will come with a recipe that says, for nectar thick, use 1 tablespoon, and so forth. Other dietary modifications, since you asked, would be moving to soft solids, so foods that are moist and soft and easier to form into a cohesive little bolus. Other dietary modifications might include eliminating troublesome foods, which would include particulate, dry, crumbly things like some peanuts, breads, popcorn, things like that. Might also call for eliminating leafy things. So lettuce is notoriously difficult to swallow because it sticks to everything. And if you don't have a strong swallow, those leafy things will just stick around. They'll hang around for a while. So if you were to take notes, I would say 1, eliminate dry, particulate, crumbly foods, peanuts, popcorn, crackers. Stick to soft, moist foods such as soft pastas, casseroles, meatloafs, things like that. And then with the liquids, if you need to go to a thickened liquid, look for a liquid thickener in your pharmacy or speak to your speech pathologist and have them guide you professionally would be the best. Does that answer your question, sir?
Yes, I think so. Thank you. Our second question was regarding, would you recommend the use of a handheld meter to measure the loudness of your own voice? Is that something one could do for themselves?
Yeah, that's an excellent strategy. People often will do that when they are in therapies because that's one of the things we do in the therapy is we hold a loudness meter and measure how loud you are. So if you're really motivated, I think that's a great way to gauge how well you're doing, and it can really also help with that calibration because you can see some numbers and you can kind of understand how loud you actually are. It's a good strategy.
Okay.
But don't let it drive you crazy.
Thank you. Our final question, under the topic of drooling, I didn't hear any mention of chewing gum. Is that useful in helping control some of the drooling?
Well, in general, chewing gum would increase the amount of saliva that you make, and so it's interesting because it's a double-edged issue. Because chewing gum will probably increase the amount of saliva any individual person may create, but because they're chewing and actively working at this little piece of gum, they'll probably start swallowing a little bit more. So it'd probably be an individual thing for any given person to see if that's something that works for them or not. The problem with Parkinson's in general is not that they make too little or too much saliva. They make just as much saliva as anyone else. They're just not swallowing it as often as they would under normal circumstances. So the speech therapist will often work with them. Someone like me would often work with them to ask them to remember to increase their frequency of swallowing. Their spouse can remind them to swallow. They can try and sit up a little bit further. And then additionally, there's some medical things that we can do to control the drooling, but we have to carefully evaluate the individual to make sure that the side effects aren't problematic for them.
Was there any difference in sugarless versus sugared gum that you're aware of?
I don't think so. I would just try different types and make sure that, and see what works for the individual. If they have any trouble with swallowing, you want to make sure that they're able to actually to control the bolus of the chewing gum in their mouth, and that doesn't become an aspiration risk for them. But other than that, I don't think it makes any difference what type of chewing gum you use.
Thank you very much.
Great question. All right, we're moving on to Coeur d'Alene, Idaho. Any questions at Coeur d'Alene?
Yes, we do.
Is there any evidence?
Great, go ahead.
Is there any evidence that deep brain stimulation surgery has any positive effect on the symptoms you've talked about today?
Yeah, it's very interesting because in general, the deep brain stimulation and a lot of the surgeries of that type for Parkinson's, swallowing, and dystonia have a very unclear effect on the voice and on the swallowing, and that the same thing goes for some of the medication trials. And in general, that was surprising to us because we thought, well, if it helps your limb symptoms, it would also probably help with the swallowing and the voice symptoms, but that's not necessarily the case. So I have some patients where the DBS improves some of the voice symptoms, and I have patients where it's done the opposite. There's been a recent study out where they think that it may be that the parameters for the limb and the parameters for the pharyngeal phase are slightly different. And so it may not be that it does or does not help. It just may be that it's not set at, there's not a parameter that covers both types of areas. But that's been something of concern. But in general, it's a flip of the coin. So as a clinician, we don't know what's going to happen when you do your DBS with regard to your voice and your swallowing issues. We don't know if it'll help or if it'll hinder.
Okay, any other questions there?
Yeah, yes, I have two questions. One is, I've heard some speech therapists use electronic pulse therapy or something on the throat to strengthen the muscles of the throat area. Is that popular? Is it effective or not effective?
That is such a good question. It's actually a really hot topic in my field. There is a type of swallowing therapy called vital stim where they do place the electrodes on the throat here, and we don't have any strong evidence that that is effective. Some very fine researchers are looking at this question, so we don't have a definitive, the research isn't all in yet. So I would probably say, since it's sort of an experimental treatment, I would probably shy away from it at this point for Parkinson's. But it, as I say, we're still looking at that. It's still a hot topic and under investigation. Good question.
Okay, my second question is relating to aspirational pneumonia is apparently a common cause of death, or a high percentage of leads to death with Parkinson's. In the extreme advances of it, is there anything that can be done for interventions, like if you still want to live, so to speak, with intubation or for feeding tubes or something? What do you do when aspirational pneumonia gets in the advanced stages?
So that's actually a good question. When it gets to the advanced stages, there's a lot of different medical therapies that we can provide to somebody. So obviously they may need to go onto a feeding tube, but if you're getting even more advanced beyond getting a feeding tube, these patients sometimes need to have a tracheotomy, depending on what their functional status is. After that, a tracheotomy is a small tube we put in the windpipe that can bypass the voice box, and then you can have access to the trachea for suctioning of secretions and things along those lines. If they have a tracheotomy, they'd probably have to have a feeding tube at the same time. We don't see this so much in Parkinson's disease, but in other progressive neurologic diseases such as Lou Gehrig's or ALS, an individual often can be fairly functional, but yet have no ability to swallow. And so in those types of cases, if they're still severely aspirating even after we've put in something like a feeding tube, then we can go on to surgical therapies like a laryngotracheal separation, where we'll actually take the trachea and separate it from the swallowing passage altogether. Unfortunately, although that completely spares the breathing aspect so that their lungs stay completely clean and they're able to have very healthy lungs, it removes their ability to speak. So for ALS, that's not as much of an issue because often in the progression of the disease, they lose their ability to speak. But for an individual with Parkinson's, that would be more of an issue. So we don't tend to see it progress to that phase as frequently. But a G-tube is something that we do see occasionally, very rarely a tracheotomy.
Okay, now was that Coeur d'Alene who just
checked in on those questions?
I think so. All right, so the next one is Colville. You're welcome. Let's go to Colville, and I just want to mention we're happy to welcome them. This is their first time here, so if you have any questions in Colville?
Good morning.
Good morning. Are you Colville? Oh, hello.
We are Colville. This is Carol.
Okay.
And first of all, it's a real privilege to get to listen to your presentation. It was wonderful, and I really enjoyed it. It's great. I had a question for Dr. Sumata. Did I get your name right? Close enough.
I'm not a doctor. You gave me a huge promotion. Thank you.
Hey, okay. On your PowerPoint, I might have missed this. It said something about, when you're talking about traditional speech therapy, you said something about protective measures. What would those,
Yes.
are those exercises or?
No, that's a very good question. So for instance, sometimes we think when we tuck our chin and swallow, it rearranges the anatomy in the throat in such a way that it protects the airway. We also think for some individuals, if you do a head turn and swallow with your head turned, it may have some benefits. But for each of these protective maneuvers, it's very, very important that they be evaluated for you specifically by a speech pathologist, usually under some kind of x-ray condition. So for instance, we have a type of swallow study that we call a modified barium swallow study. And when we do those swallow studies, we can look and see how effective those protective maneuvers are for any particular individual. They are not universally protective, but there are ways to protect the airway by altering your posture and using maneuvers. A protective maneuver might be something, fancy name, we all have fancy names for these things, called a supraglottic swallow. And that is simply, I've got my bottle of water, I don't know if you can see me, but I'm gonna hold my breath, sip and swallow, and then give it a little cough at the end. And that is a way of swallowing that accentuates the airway closure. So you're actually, when you hold your breath, you're closing your airway. When you hold your breath and bear down a little bit, you're closing it really tight. So that's an example of a maneuver that's designed to protect the airway. But again, it is not for everybody. And this is particularly a strategy that you don't want to use if you also have a heart condition. Again, very important that you be guided by a good speech pathologist in your choice of these maneuvers.
I think we have a second question here.
Sometimes when answering the telephone, if I don't think about it ahead, I'll go to speak and I can't speak because of mucus. And is that caused from the Parkinson's?
You know, that's a good question. That actually might be a symptom of the not swallowing enough. So when we swallow, we also kind of push the mucus that sits in our throat, we push it down the esophagus. If you're not swallowing frequently enough, you'll get a buildup in that area. And so when you go to talk, you'll kind of have a wet, gurgly voice or not be able to get some sound out. So it could be a symptom of that. Mucus is also a symptom of some other things too, but that's certainly possible. That's a very vague answer, isn't it?
We often find that they are very individual. So, all right, Colville, well, welcome again, and we're going to move on to Dayton.
Thank you.
Dayton General, do we have anyone there with a question?
Colville is cute.
Push the button. Then talk and push it again.
Okay, Dayton. Oh, now re-push the button. There. Okay, do you have a question? Folks in Dayton?
We have no questions.
Okay, well, thank you.
Thank you.
Grangeville, Idaho. Did he change his mind? Grangeville, Idaho. Okay. Let's try and move on to Kennewick. Kennewick General Hospital.
This is Kennewick, and it was a great talk. I could
do you
personally
have any-
identify with most of the symptoms described, but I don't think we have any questions.
Okay, well, thank you for being there, and we appreciate
you.
the compliment on the talk. Okay, how about Kirkland, Evergreen Hospital?
I wonder if I'm supposed to press this again.
If that's Kennewick, you should put it on mute. It should be lit up red. Anyone at Kirkland? Okay, let's try and go to Miles City, Montana. Seem to be stuck in Kennewick. Miles City, anyone there with a question? Okay, how about Moses Lake? I think we're still connected just because we're looking at a place, right?
Yeah, they have to unmute.
These guys are...
Someone unmuting will take over the screen.
Oh, okay. So as we're going to these other locations, as I call it, if you have a question, unmute your button. So we'll try Moses Lake again. Okay, how about Port Townsend? Pullman? Ritzville?
Ritzville has a question.
Great, okay, go ahead.
Yes. The talks were right down my line today. It's one of the best I've had because it fit me exactly. And I have one thing that you didn't mention, and that's a lot of dry throat. And I wake up and sometimes my tongue is almost just can't even hardly move it. It's so dry. And I keep a bottle of water by the bed even at night, and I have to sip on it every once in a while. And also my voice. I used to sing quite a lot in church and so forth, and I just about can't sing at all anymore. And I don't know what gotten into it, and I eat real slow. I go to a restaurant to eat with other people, and I'm always the last one sitting there, and it kind of bothers me. I don't know what to do about it. Now, Spokane said that they have a singing thing that they use, which sounded good, and I would like to know if you can get in on it, or I'm 60 miles, well, I'm 80 miles away from Spokane, but I drive up there a lot, so I don't know whether I could get in on that or not. Can you give me any answers?
I
don't know anything about this.
There is that program.
Right. So can we get your name? Could you write down? What's your name, and we can have Spokane connect with you?
Lester Snyder, S-N-Y-D-E-R.
Okay, Lester. And is there a phone number for you?
659-0235. I have an answering system.
Okay, so we'll have someone from the Spokane group get in touch with you about the singing part.
Okay.
And I'm not sure if our speakers have any other comments about the dryness, perhaps.
So, Mr. Snyder, the dryness is difficult, as I had mentioned before, with the Parkinson's. It's not so much that you have too much saliva. In fact, you may not have enough. And especially with a lot of the medications, either the medications for the neurologic disease or other medications that you're taking can have a certain amount of drying effects to them. So that's something that you can go over with your physician. You're already doing the right thing by drinking enough water. Another issue may be that as you're sleeping at nighttime, you may have your mouth open, and so you're breathing dry air all night through your mouth, and that may cause you to have a dry mouth in the morning. But aside from increasing your water intake and taking care that you're not on excessive medications that would dry your throat, we don't have a lot of things that will make your throat a lot more moist. One of the things you could do is perhaps the chewing gum that one of the other sites had mentioned, because the chewing gum will actually increase the amount of saliva you make, but it's hard to chew gum while you're sleeping. So that's a downside for that.
I have a lot of drooling too.
And then
I have a lot of drooling too.
So that's right. So maybe you want to try the chewing gum, and then if that's still problematic to you, then you can talk to your regular doctor and see if they have any issues for that. But you may have one treatment may make the other thing worse if that's one of the cases that you have. So we just have to be careful that we don't.
It's mostly when I eat.
Go from when
I eat, it's very.
You drool.
Yes, I'll start drooling, and even my nose will run, and I'll have to keep a handkerchief handy all the time when I'm eating because my nose.
So the nose running is a completely separate issue. That's probably called vasomotor rhinitis, and that's completely separate from anything else. And that's something that your local ENT may be able to help you with quite quickly. But it sounds like with the eating and some of the issues that you have with your eating that it may be worthwhile for you to see a voice or a swallowing specialist so that they can watch you eat and see what your problems are and see if they can help you with some of those things.
I've been through that test. I've been through that test over quite well.
The swallowing
they said
test?
there was nothing wrong. The swallowing test, yes. And all of that test. I went through both upper and lower and everything on that, and they couldn't find anything wrong. My doctor's really.
Yeah.
That's it, I guess.
Mr. Snyder, I also want to throw one more thing out there, which is I'm not flogging any products. I really don't represent any companies, but there is a brand line of products that for oral care called Biotene, Biotene. And this is a line that specializes in care for dry mouth. They make toothpaste, mouthwash, gels that can decrease the symptoms a little bit and improve, just make it feel a little bit better. Biotene, yeah, that's something to try, but you're doing the right thing by drinking plenty of water, okay? Yeah.
Okay. All right, we'll move on. Thank you, and we'll get in touch with you from Spokane. So Sandpoint, Idaho, anyone to check in from Sandpoint? And Seattle, Virginia Mason, we had an opportunity to have some of our questions answered during the little break, but anything else? Okay. Spokane, we normally have some folks in Spokane. Anyone there have a question?
We're moving the mic around. Bear with us 1 second.
Here you are.
Okay.
My comments and question involve the therapies for voice quality. It's my understanding that LSVT is individual-based therapy, and the music and choral therapy is a group type of an operation. Now, the group singing has the social aspect of it too, which is beneficial to the individuals. I recently heard of a therapy called the Texas Voice Project that was based on LSVT, but it is designed for groups. Do you have any knowledge of this particular type of therapy and how effective it might be?
I have heard of some folks trying to use the LSVT in a group setting. I am not sure that the originators, the investigators who developed LSVT would feel really good about that. However, intuitively, I think it's a great idea. I don't see why you wouldn't want to try it because you do have that added benefit of the social contact. The benefit of doing 1 or 2 sessions individually with a speech pathologist, it would be to guide each person individually. So we're all a little different. We all have different needs. That would be something where individual attention would be good. But I don't know any specifics about the Texas Voice Project. I've always thought it was a great intuitive leap from individual therapy to group LSVT. But let's hope somebody's writing a paper and doing a study and that will help us kind of get more of these therapies developed and out there? It's a good question.
Okay, and just one other comment for Mr. Snyder in Ritzville and anyone else who is interested. The Treble Clefs will be singing on Wednesday at the Spokane Street Music Week. This is an annual event that's put on for the benefit of the Second Harvest Food Bank, and we'll be singing from noon to 1 o'clock. And if Mr. Snyder or anybody else happens to be downtown on Main Street in front of Macy's, just stop by and join in. Thank you.
Well, that's great. Thank you for sharing that. Any other questions?
Anybody else? That's it for Spokane, I guess.
All right. We have Tonasket, North Valley Hospital.
No questions, thank you.
Okay, thank you. And Walla Walla, Providence St. Mary's Medical Center. And last but not least, of course, OMAC Medical Center, it looks like. OMAC, anyone with a question? You did your Tonasket? All right, then that concludes our program for today. And we want to just, again, thank our speakers immensely. It was a tremendous program. Really appreciate it. And we hope you all got some good and valuable information out of it. Please be sure and check the website of Northwest Parkinson's Foundation for the monthly announcement of each of the telehealth programs. So the second Monday of each month. And so we'll see you again in July. So thanks again.